I'm Nicole Trevino, excited to talk with you today about engaging youth and families of color. My co-host is Brittany Cavill. We are both, I'm a consultant, I have my own company, but we're both also a part of the Travis County Adolescent Health Collaborative here locally. And so we work with providers and youth serving organizations to help improve adolescent health services across a variety of areas and focus areas, professional groups within this local community. My background is in adolescent health education and risk-taking behaviors. I also have worked on positive youth development programs and improving systems to support adolescent health. So a lot of my work has focused on, just doing some of the development opportunities, training, and collaboration building to support the adolescent health infrastructure here in Austin and Travis County.
Hello, everyone. My name is Brittany Cavill, and a lot of my work has similarly been around positive youth development and working with teens and young adults. I have lots of experience also in community engagement and helping organizations find creative strategies to reaching the populations that they're looking to serve, specifically communities of color. And most recently, I have been working with the Texas Institute for Excellence in Mental Health on improving systems of care for adolescent mental health systems.
So we are not doctors. However, today we're going to be sharing a little bit about our own story as adolescent health patients. And we're also I'm going to use those stories. We do a lot of cultural sharing through the Travis County Adolescent Health Collaborative, which will now be truncated to TCOC Collaborative for the sake of, shortening that mouthful. But we do a lot of work in TCOC on cultural sharing and integrating culture into our professional world as a way to start breaking down racism and the things that still perpetuate barriers in better serving communities of color, of which we're both a part of, two separate communities of color. And so we're using the vehicle of storytelling about our own experiences as a way to highlight some of the aspects of adolescent health in healthcare. And a lot of this applies in other areas as well, but using that storytelling piece to highlight some of the recommendations that we have. So I'll start first with my adolescent health story. So I've included some cute pictures of my baby self there, right? The cutest being the smallest version of me. I am, part of a Mexican-American family, grew up in San Antonio. And even at that teeny tiny, very adorable age, was very sick. I was hospitalized in the first few months of my life for RSV. So I was hospitalized for several weeks. It's still, after leaving the hospital, after going through treatment for that, still had some breathing issues and trouble getting air in and getting enough oxygen. And so throughout my childhood, I visited doctor after doctor after doctor, specialists, tons of testing. And no matter how many places we went that my parents would take me to, and I grew up outside of San Antonio, Texas, so I had access to the South Texas Medical Center. But even with all of the healthcare that we were accessing, we still couldn't get answers for why I was having a difficult time breathing, chronic cough, wheezing, and just frequent infections, right? So my entire childhood, my parents tried to give me this really normal childhood. You can see there I was in Girl Scouts. I had lots of friends showing up to my birthday party. So I still had a pretty good life for a kid, even though what most of my friends couldn't see is that I felt really bad most of the time. And so, after years and years of, trying to find answers and get healthcare that would actually get us somewhere to a treatment option, we still were nowhere, and I was 10. And it started to take an emotional toll on me, right? Experiencing life in this stage of being an adolescent and all of the things that come with adolescence, like being self-conscious about your body and wanting to know if you're normal. And I could tell that I really wasn't normal, but I really had no one to talk to about it. And so it really started to take a toll on me after a while. And again, my physical health was deteriorating over that first 10 years of life. You hear often, patients that don't have private insurance sometimes encounter a not so positive experience in the healthcare world. But I had private insurance, and it's not like my family was well off. They absolutely were not. But it wasn't like any of the healthcare providers ever experienced us having an inability to pay, or that there was some kind of economic thing that any healthcare setting we were interacting with could see. Again, saw lots of doctors, lots of testing, and all of this kind of came to a head at 10 when a healthcare provider doctors, the supposed best pediatric ENT in San Antonio that had come highly recommended from many people, told my family, "I don't know what you want me to tell you. There's nothing wrong with your daughter. It's all in her head." And that was about the most frustrating thing that you can experience as a parent who is seeing your kids struggle and seeing your kids suffer. Coincidentally, weeks later, from this person telling my family that there was nothing wrong with me, and then it was all in my head, I was hospitalized and very near respiratory failure. So my diagnosis is actually a very rare disease, right? It's reasonable why no one could figure this out, because it's an ultra rare congenital condition. But most kids who get diagnosed with this condition are not diagnosed at 10. Most of them are diagnosed within, usually within the first couple of years of life. And definitely within that, middle childhood, 5, 7 years old, is often, kind of the later stages of when someone might be diagnosed with the condition I had, which is congenital tracheal stenosis. As a result of a decade of not being able to breathe and not being given any treatment whatsoever that would help my condition, and folks not even looking at the scans that, again, the same person that was like, it's all in her head, the same scans that person should have looked at were clear as day to the doctor who ended up saving my life, who's named Dr. Mo. So once I found Dr. Mo, or rather Dr. Mo found me, I, had a much better experience in the healthcare world, right? I at least was able to get some relief from the issue that I was struggling with. I had 9 surgeries between ages 10 to 18, which is a lot. It's a lot for a kid to go through at that age when you should be enjoying yourself and being, just a kid. I did daily nebulizer treatments. I think I was at like 4 nebulizer treatments a day. So a healthcare regimen that was pretty hard for a kid to manage, and really, really not something you want to take to the sleepover and be the only kid there doing a breathing treatment. So all of that to say, thankfully, I finally got into care, and I got much better care once I got diagnosed. But that the treatment at that point was much more severe as a result of how severe my condition had gotten. And then, the one piece that no one in all of the many healthcare providers I was seeing, from respiratory therapists to doctors, that was untreated still, was the mental health impact of experiencing a chronic illness and a catastrophic kind of traumatic healthcare situation that I went through. And so now I have Brittany share her adolescent health story.
Thank you, Nicole. So a little background on me. I come from a very rural town in Southern Illinois, and teen pregnancy rates are, when I was growing up, was extremely high. So my family members, my older cousins, friends, they all ended up pregnant. And so it was very important in my family for me not to get pregnant. It was a milestone that I was able to get through high school, and I was not pregnant. I did not have a child when I graduated high school. And so that was to the success of my mother, who put me on birth control in middle school. And she was very intentional about communicating with me about my reproductive health. And so from an early age, I had an OB that I saw regularly, and we built trust and conversations around my reproductive health. And so when I went off to college, I went 5 hours away from home. So I was alone, and I wasn't used to having to find a doctor for myself. And I hadn't ever been to a Planned Parenthood. I hadn't ever been to a community clinic. So I wasn't aware of those resources, and I didn't really know how to access them. And so because of that, there was a lapse in me being able to receive my birth control. And during that lapse, I was a freshman in college, and I ended up getting pregnant with twins. And so prior to this, I had no major healthcare issues. Because I was carrying twins, my pregnancy was classified as a high-risk pregnancy, and I was very small. I believe I probably had just barely broke 100 pounds when I was 19 and pregnant with twins. And so my pregnancy was rough, and I was sick throughout the entire pregnancy, but I made it through. I made it to the third trimester, and I ended up going into preterm labor. And so I'm 19, I'm 5 hours away from home, and I go into preterm labor, and I go into the hospital, and I find out that my doctor that had been giving me treatment, who I had built this relationship with throughout my entire pregnancy, had just left the practice. And so I was told that another doctor from the practice is going to have to deliver my babies for me. And I'm like, okay, I mean, that's what we're going to have to do. And so in that moment, the doctor comes in and he explains to me that both of my babies are head down, and I can deliver vaginally, but since it's a high-risk pregnancy and there's twins, and there's a possibility that when one baby comes out, the other baby can flip around, and then I have to have a C-section, that I can have a C-section if I wanted to. And so at 19, all I heard was that you can have a vaginal delivery with one baby, and then you can possibly have to have a C-section. And so what made logical sense to me was just have the C-section so that I'm not hurting in multiple places for recovery. I thought the recovery would be easier. So the C-section went fine. And when I woke up, I was on a morphine drip for the first, I believe, 12 hours. And then they stopped allowing me to have morphine and just gave me regular pain medication. The moment the morphine was out of my system, I knew that something was wrong with me. I was in excruciating pain, a pain I had never felt before in my life. And I was repeatedly told by the doctors, the nurses, that I just needed to have a bowel movement, that nothing was wrong. This is typical. I need to walk around. And as soon as I have a bowel movement, everything will be fine. Well, it took, I believe, 2 more days for me to have a bowel movement, with lots of help for this bowel movement to come. And so finally, I had a bowel movement, and they allowed me to be discharged. But I was still in pain, and I still told them something is wrong with me. Like, I couldn't physically stand up straight. I knew that something was wrong with my body. I also was not able to breastfeed. My milk wasn't coming. Like, I knew something was wrong with my body. They still discharged me, and they told me everything will be fine and to just take the pain medication, and eventually everything will go away. Well, at my baby's first well child checkup, I took them to our family doctor, and she actually noticed that I was in pain and that something was wrong with me. And so it wasn't my appointment, but she took a liking to our entire family. And so she actually ran tests on me, and I immediately had to go to the emergency room and find someone to watch my newborn babies. I'm 19. All of my friends are same age as me. My family has left town. And so I had to call my family and tell them, hey, I have to go into the emergency room. I have to have an emergency surgery because my family doctor just told me that my colon was punctured. And she says that I have to go into surgery right now. And so they had to do an emergency exploratory surgery to repair the puncture in my colon. And that instance, that situation extremely traumatized me. From that moment, my life flashed before my eyes because I wasn't being listened to. And if my family doctor hadn't paid attention to me being in pain, if she hadn't asked me how I was doing, I very much could have passed away, and I could have been yet another statistic of a woman of color dying because of childbirth. And so I was 19 when all of this happened, and it has impacted me and the way that I interact with healthcare services moving forward.
Yeah, thanks, Brittany. Yeah, as you all can see, these are two experiences, and I wish I could say that these experiences that Brittany and I have, while they may seem kind of extreme, these are things that happen to folks in our community all the time, and you know, part of you know, some of the important lessons that we'll share from these stories is why it's important to listen and really believe what your patients are telling you, even though we know that sometimes young people may exaggerate, or we know that sometimes young people it may seem more intense to them than what it may actually be physically. But this is the point of, like, dig deeper for some of those answers. Look at the whole patient, even if it is kind of a peace of mind situation. Maybe, you know, offer at least to dig a little deeper. My dad and I actually talked to both my parents leading up to this presentation to get their perspectives. And my dad said, yeah, you know, one of the things that strikes me is that, do I know for sure that we were being discriminated against or being dismissed because of what I look like in our ethnicity? I don't know for sure, but I know that I can feel it when it's happening. And so it's hard to pinpoint exactly what's happening, but it's that sense of condescension, or that, oh, there's something wrong with you, but we're not willing to look any further than you coming into this appointment or you saying something and we noted in the chart. And so digging deeper is really critical. You know, looking at that continuity of care that Brittany mentioned, right? If someone had helped kind of think about the transition plan, it was really nice to hear people talk about their transition planning prior to this session, because that continuity, especially in that post-pediatric kind of healthcare time, is really critical, because there's so much going on in your life as you're transitioning into college or post-high school and maybe out of your parents' home. And then consider the impact of health issues. And I also have down there at the bottom medical debt and healthcare challenges of youth and families, and what that feels like to experience both the health issue and the subsequent mental health kind of component of it, or the financial well-being kind of component of it.
I think for me, one thing that stood out in my experience is that the point that we're making to show care and patience for youth parent frustrations with healthcare My family provider she ran a very small practice. And so she was very human centered. And I honestly believe that that's the only reason that she identified that I was in pain and that I was struggling and that I needed help, because she wasn't operating in this very big system. She wasn't operating with lots of policies and rules around um, how I'm going to be in her office, because she probably didn't have that many patients. And so she was really able to have a human centered approach to her work with me. And it allowed her to give my entire family care, and not just the babies who had the appointment that day.
Mm-hmm. Yeah, good point. And you know, I think one key piece is that many of you may serve a particular population, right? And there are health issues that may disproportionately impact that population. But what are the, you know, knowing what some of those things are is really helpful for being able to provide adequate care to them, to know which things that they might be more susceptible for, based on their culture, their family history, or ethnic history. You know, some of those things can really play into some of the things that that they may be experiencing. So looking at it with that lens of the issues that disproportionately impact the groups that you serve. All right, so a few things that we've touched on, and I'll drop these links to the slides in just a moment, but we just want to highlight a few definitions. So we've touched a little bit on medical trauma, right? And in specifically kind of pediatric or adolescent health medical trauma, medical traumatic stress can refer to a set of psychological and physiological responses that children and their families experience as a result of pain, injury, serious illness, medical procedures, and invasive or frightening treatments that they've experienced. And so it doesn't take more than one serious health issue to result in medical trauma for a young person. And as Brittany said, and I'll echo that same piece, this shapes the way we access healthcare to this day for both of us, I think. For me, I do not see white healthcare providers, and I know many of you are white healthcare providers, so apologies about that. But when it's life or death for me and my family, I just can't take that risk again. I can't roll the dice after 10 years of life experiencing that. And so, it shapes the way our entire families and the people who love us and care for us in our communities experience the healthcare system, even those that didn't personally experience it with us, extended family, cousins, and others. So it's something to keep in mind. Next piece is systemic racism. And we talk a lot about systemic racism in our work together. But, you know, people often push back on this sense of racism, like, oh, I'm not racist. I've never used a slur. I've never whatever. And it's easy to put this view of yourself out there, or be resistant to acknowledging that racism isn't just about using slurs. It's also about our systems and the functioning of our society, and how it's embedded into policies, practices, organizations, institutions. And then all of us as members of those institutions and of those organizations uphold this status quo. So 9 minutes is, 9 to 15 minutes is not an adequate amount of time to see a patient who's coming in for anything other than a well baby check or a well child check. But nonetheless, that's the time that you are given as a result of some of these systemic decisions that are made that aren't about optimizing the care for patients that need you the most, but about optimizing the billables for your organization to stay afloat, which is a valid piece. But nonetheless, there's a lot of people that fall through the cracks in that system. And so instead of saying, I don't see race, or I don't see color, acknowledging that systemic racism exists everywhere in every aspect and every facet of society. And that every one of us, even those of us that are people of color ourselves, are a part of this system of oppression and a part of systemic racism. And then the final one, historical trauma, and there's a lot here. I'll post a link to the slides, but historical traumas about those intergenerational traumatic experiences that are experienced by a cultural group and could even be by a family group, and that has a history of being systematically oppressed. So a few examples there, some of them medical, right? Like eugenics and forced sterilization, or medical experimentation and things like that. So when we look at systems, we've highlighted just a few things here that are systemic issues, right? Things like insurance, reimbursements, lack of diversity in providers and leaderships on, leadership members on board of directors in public health clinics or hospital systems, lack of engagement with communities or patients, those policies and procedural issues like the, truncated scheduling and optimizing billable time. And then, lack of cultural competency, even if we can't easily fix the lack of diversity in providers, like at the drop of a hat, we can still work toward cultural competency, but we have to have, our providers given time to do those kinds of educational trainings and development opportunities in order to see improvement there. And then patient, accessibility and affordability, even for clinics that are public health clinics that provide services to patients that don't pay for the services directly, there still may be accessibility options that are not dealt with that can create barriers to them accessing care.
We also wanted to provide you all with some examples of how racism can be baked into how services are actually provided to your community. And so the first is that family and youth engagement is often an afterthought. And so what we mean by this is we tend to do research and we tend to see outcomes and we say something's wrong here. We're not able to truly serve the populations that are being hurt the most by certain issues. And so then we start to rally our resources and think about creative strategies to engage these populations. But we know that engaging with other cultures, you have to learn their cultures, you have to build relationships. And so that engagement piece shouldn't be an afterthought. It shouldn't be after we realize that we're not seeing outcomes. It should be the way in which we are approaching healthcare services. And oftentimes a lot of community clinics, they don't have the resources to really be engaging. They don't have the ability to utilize their funds to think outside of the box. We also have, me personally, I've experienced providers having very condescending tones and speaking in a way that I don't really understand. And so when I was that 19-year-old and that doctor told me, basically what I heard was get the C-section. You need to get the C-section. And so I didn't understand what he was meaning. And I didn't want to challenge that authority because he's my doctor. He's the provider. I should listen. And so that is inherently racist because it took my voice out of the situation. It didn't allow me to approach the conversation or the interaction with all the tools that I needed to make the best decision for me. And so we want to make sure that healthcare providers are finding ways to be respectful, respect culture. And so my grandmother, she wholeheartedly believes that putting Mentholate on a baby's feet is going to cure them of all sicknesses. And so when you have a grandmother that's coming in and this is the strategy that they're taking and they're not seeing results, you have to find a good balance to not tell her that that's wrong, you shouldn't do that, but to give some other options or to explain why she might not be seeing the results that she wants to see without disrespecting the culture. Oftentimes, people of color, people from marginalized communities, they experience extreme amounts of trauma that is really truncated, and there's layers there. And so when you are providing healthcare services, it's important that you really take that into consideration, and that the clinic should look at their approach to see how are they providing holistic services so that they can be minimizing the amount of traumatic experiences that their community is facing. And so you aren't just there to provide healthcare services, but in what ways can you connect with other resources that can help your family? Because if your patient is dealing with housing insecurity, or they just lost their job, no amount of medicine is going to be able to take away those issues. No amount of therapy is going to be able to take away those issues. So how are you connecting to resources and providing holistic services so that you can be more effective in their healthcare? And then lastly, lots of times spaces don't feel welcoming. And so take a critical look around your space. Do young people feel like this is an inviting space for them? Do people of color see themselves in the pictures that's around the walls? Do you have different languages present? Are your instructions in different languages? Is your paperwork? Do you have translators? People really need to feel connected and welcome in the space that they're getting healthcare services, so that they can break down those barriers and break down the guard that they may have, and really trust the healthcare that they're receiving, so that you can provide great care that's going to help them for the longevity of their life. So changing our ways, we have come up with a list of critical issues to address in healthcare. And Nicole and I are going to explain this slide together, but for me, staffing should be reflective of youth and families. And I actually was just presenting today about this strategy. And when you want to see major demographic shifts within the staff of systems, within the staff of organizations, it's really a long-term approach that you should be taking. It's an approach that requires you to work with schools, to work with families, to ensure that the young people have the tools and resources that they need so that college is a reality for them, because that is the first step for them to receive the education that they need to be a part of the staff of the organizations that we want to be reflective of the community. And so it's important that if this is a goal, that you really realize that it starts when the child is younger, and the approach is a long-term approach and not something that can be an afterthought. You can't just go into communities that have been oppressed and expect to find the resources, or expect to find people with the resources to come and work for your agency when they just haven't been given that same path. Also, sharing power within decision-making. And so again, going back to my story, I really didn't have the power in that situation. I was the mother, I was above 18, but I wholeheartedly feel like I was coerced into the surgery. And how can we improve those interactions between healthcare providers and their patients? We really want to find opportunities for power to be shared and for information to be shared so that people can make the decisions that they need for their healthcare.
Yeah, I think that's really important, Brittany, seeing your patients as partners. Though they may be young people, they are young people that are experts in their lives. So for a while, there was a big push, and I think there probably still is, around long-acting reversible contraceptives, which I may use personally myself, and I think they're a great method for me. But missing from some of the dialogue around this big push for getting teens on LARCs was what happens if this young person doesn't have like the program that paid for it to be inserted is not still available when it needs to come out, or there's an issue with it and they need to, go in for an additional doctor's appointment before that, window for them to get it out. Or is it going to be the best choice for them for the next 5 years or 10 years that you're putting a device in? And do they feel like they can push back if you're being even a little bit pushy? Did they feel like they have the power to push back and say, no, I really want birth control pills, even though you think this will be easier? I like the idea of being able to change my method if, my situation changes, or being able to have the security of knowing that I'm taking it every day. So that's part of sharing power and avoiding coercion, but it's also, honoring young people and their families' desires for their healthcare and seeing them as partners in healthcare decision-making. So you are the medical expert if you're a doctor or a nurse, and, working in a clinical setting, even as a health educator, but it is really important that you start to build those skills for young people to make decisions, weigh options for themselves, and build those skills for long-term, throughout the life course, good medical decision-making that's informed and that's free, free choice to make the decisions that are right for them. And so building those positive interactions, I think about Dr. Mo, my ENT that saved my life. He used to tell me, and he really tried to break me of this habit. Every time he'd come in and I'd be in the hospital, he'd say, "How are you?" And I'd say, "I'm fine." And he's like, "You're not fine. If you're here, you're not fine. So stop saying you're fine when you're not fine." But I have to think that somewhere in my little mind overheard these conversations of people telling my parents, it's all in her head. She's making it up over and over and over again. And so, then I learned to smooth it over for the adults who can't handle that I don't feel well. And so those kind of things stay with you throughout your life, and they can really shape the way you access healthcare for years and decades to come. So, those things are important. One of our young colleagues in a presentation earlier today talked about, just advice for providers. And they said, if it seems like you're in a time crunch, like the ticking time bombs, winding down, it's really hard for me to feel like I can be comfortable asking you questions or talking to you about the things that are important to me or what I'm feeling, because we don't have that relationship. And that, I think, also goes to that piece of there's got to be funding. There's got to be a little bit of investment made on the organization's part to engage with the community and engage with your patients and build those relationships and build rapport, and do other things like cultural competency training that a lot of doctors just don't get enough time out of the clinic, and nurses too don't get enough time out of the clinical hours to be able to really focus in on improving that quality of care that can be so important for understanding how to best treat their patients. And then the final piece, centering culture in our treatment options and in the conversations that we're having with young people and their families, not doing culture neutral kind of services, but really seeing culture as part of prevention and as part of our medical intervention. So thinking about ways to learn about their culture and then take what you know about their culture, what you're learning, to ask better questions, more informed questions. So things like, if you're taught that you should defer to a doctor's medical opinion, you might be less likely to ask questions. Or if you've been treated like you're dumb, you might not want to ask questions. But not asking questions doesn't mean you don't have questions. It may be a cultural issue, or it may be that you've been conditioned by other providers to not question their authority. So I know we're at time, but any questions that we can answer while we're on?
What are some other questions you can teach your patients to ask so they can grab some power in the situation?
Yeah, I think sometimes phrasing it as like open-ended, what questions do you have versus do you have any questions is a yes or no versus what questions do you have means I'm setting an expectation that you probably do have questions. Or things like, okay, it's okay if you don't have any questions, but some of my patients have questions about any side effects or things that they've heard about this treatment option. And volunteering a little bit of that, which may spark some questions that come up as you're explaining some information. So no questions might mean you need to volunteer a little more so that they can formulate a question.
I like also what was helpful or what has been helpful for me is to ask what's going on, build a relationship and let's have a conversation about what's going on. And then as the provider, that could give you more insight into what questions you should be asking. What follow-up questions do you need to ask? And my daughter is going to make a cameo.
Hello, Maya.
Maya.
Any other questions?
I think also addressing internalized racism as part of our growing process, so and it has different manifestations for white folks than it does for people of color. Mm-hmm. But yeah, so it's not only that, it's the questions that the patient can ask, right? Or that we can advocate for the patient, but we also have to deal with the systemic issues in terms of racism, like you have mentioned before, so that the onus isn't on the folks who have been oppressed, but that the onus is on, right, the systems that have been, and those systems are, made up of people. So. Yeah,
it's important reminders. I was very apprehensive about doing this presentation today because I've been training doctors and providers for a long time. And oftentimes they are some of the most resistant audience to hearing from folks who are non-healthcare providers. But, folks that have been patients, especially as extensive a patient as I have been, have a lot of experience of what it feels like on the other side of things. And so recognizing that there's kind of the two sides to it, right? That there's expertise on both sides, on the patient and on the provider.
Nicole and Brittany, I just have one question. I know we're a little bit over time, but I wonder if you could talk about, I know that you'd mentioned in this presentation sort of the limitations with which providers can sometimes operate under, whether that's time constraints or different factors such as those. We, ELB1 utilizes community health workers, and I know that other clinics do as well. Can you talk a little bit about the roles that community health workers could play in addressing these particular issues?
Yeah, community health workers are one of the best ways for clinics to find folks to work in the clinic or in the setting that you're working in that might best match the community that you're serving. Even if your providers don't at the moment, they may be able to support more linguistically appropriate services, translation of materials and information. But far too often they are not listened to as well for their own expertise coming from the communities that the clinics they work in serve. So while they may have great rapport and great connection with patients and clients that are coming in, they often aren't elevated at the level of expertise as providers. And that's a disservice, I think, to any clinic that has health educators or community health workers that aren't given those opportunities, because they can be some of the folks that know the community you're trying to serve better than a lot of the providers may. And yet, they're not rewarded for that expertise. And so I think that, community health workers can play a vital role in helping take the information that can be complex and put it into methods of communication and materials and interactions that help your patients make sense of what their provider has shared and can help coordinate care, make referrals and linkages that can be so essential to meeting the holistic needs of the young person and their families. And I'll also do a little plug for some of the handouts I shared. Some of you may be familiar with the class standards. We've identified a few sort of notes and ideas on how to take a look at those class standards, which come from the Minority Health, Federal Office of Minority Health. And then here's our little notes as a crosswalk of things that you can do within your organizational practices and policies, as well as some further reading and development, and then look at the comments, because Angelica also dropped in some really great books. I incorporated here just some great toolkits, some articles from healthcare kind of organizations, but then also a few different documentaries and other organizations that we really like that are more on the progressive side of supporting communities of color and addressing some of the issues that they uniquely experience in healthcare settings. So a couple of handouts there for you all.
So this is Vanessa, and I'm supposed to be helping moderate the session.
I know, sorry. I know.
Thank you so much, Nicole, for sharing those resources. They're in the chat box as well. For those who are interested in the final networking session, it started at 8:20. It's going to conclude at 8:30. So you would need to exit and go to that link on the agenda. But thank you so much, and Brittany and Nicole, for a great presentation today. And will you have this information posted?
Yes, we are going to send this to Anne-Marie to get posted, and then I dropped links into the chat box just now.
Thank you. All right, thank you, everybody.
Thank you.
Thanks, everyone.
Great job, both of you.
Thank you, appreciate it.
Oh.
Thanks, Angelica, for being here.
No worries, of course. Gotta support.
You're always like our hype in the crowd.
Right. I'm your hype woman.
You're a hype woman, our backup, giving us some extra pieces, all the holes of extra experience and notes and things that you have. Like you're always so good.
All right, I'm going to go ahead and close out, let you guys join the final networking if you would like. Thank you so much again. This has been awesome.
Oh, thank you. Appreciate it. Thanks for moderating, Vanessa. Sorry we went over.
I was like, this is so good. I can't tell her to, she's got 1 minute left.
30 minutes is so hard, but yeah, we appreciate you all.
Thank you. Bye-bye, Brittany and Nicole.
Bye.
Bye.